The scanning plans for the liver are longitudinal in the epigastric region, then subcostal sweep, again longitudinal, then angling in this direction. Subcostal, initial one was absolutely straight below the subcostal margin up to the lumbar region. Second one is longitudinal, then angling, then transverse, epigastric region, angling it, capilloid, then straight capilloid, angling towards the patient's face if required, lateral angling in about 45 degrees or 60 degrees angle. You may have to ask the patient to take a deep breath and hold it in case if you don't see the transverse section of the liver, the portal veins, and in this posture and in this position, in this scanning plan, you don't see the hepatic veins. Then you may have to give pressure. And maneuver it in this section, in this way. Second plan that is used for the ultrasound of the liver is the intercostal plan. These are the intercostal plans. This is the intercostal plan with patient supine. Now for the comparison of the right kidney with the liver or liver with the right kidney, in the lumbar region, almost in the intercostal space, lumbar region maneuvering in this direction, or placing the probe in this down in the subcostal region. In the subcostal region, asking the patient to take a deep breath and hold it, and then moving the probe according to the requirement so that you can see the liver and right kidney together for the comparison of the parenchyma of both organs. Liver parenchyma is slightly more than that of the right kidney's parenchyma, provided the right kidney is normal. Curved lobe. Then we have to scan the patient in left lateral decubitus posture, placing the probe longitudinally to start with. Then again you angle it. All the angling is done here in the epigastric region. I place the probe longitudinally in the epigastric region. I'm angling it over here, and this is mainly to see the portal vein, porta hepatis. Then we move the probe upwards in the intercostal space. These intercostal spaces are used to scan the portal vein and its branches. But the posterior branch of the right portal vein, we turn this way. We will have to move the probe in this way downwards, and for the anterior branch we may have to angle it upwards. It will all depend upon the patient size. Ideal scan is that we perform on a thin patient. Then this is one view in which place the probe in this subcostal region, give some pressure, angle it cephaloid, and ask the patient to take a deep breath so that you can see all of the liver parenchyma with diaphragm. Then this is another view. You place the probe in the subcostal region. Here, move it downwards. This will clear you if there is any fluid above the diaphragm or there is any pleural effusion. Even if you place the probe in this direction, under the subcostal region, ask the patient to take a deep breath if he can. If the pleural effusion is present, then you will see fluid above the diaphragm even in this angle. Small amount of pleural effusion, however, may not be seen in this scanning plan, for which this is the proper scan. The probe in the intercostal region, you can get over here and then angling it in this direction very slowly, gradually. Here, slowly and very gradually. Now, again to see the kidney and the liver parenchyma, you may have to place the probe under the subcostal region with little pressure. Ask the patient to take a deep breath, and you will see kidney and liver both to compare the parenchymal echogenicity. So these are one of the few plans that we use. If I place the probe here, ask the patient to take a deep breath, I will see the gallbladder with water vein.